Good day. Our topic for today is your endocrine system pharmacology. So first, let's review. Endocrine versus your nervous system. Unlike your nervous system, which uses your neurotransmitters, your endocrine system uses your chemical signals such as your hormones for your long-distance communication. And these are your major endocrine glands in our body. So we have your pituitary, thyroid, adrenal, and your pancreas. Your pituitary is your command center of your endocrine system. We have your thyroid, which regulates your metabolism by having your T3 and T4. Your adrenal is your stress response. So we have your mineralocorticoids and your glucocorticoids, and your pancreas, which regulates your blood glucose via your insulin and your glucagon. So in hormone transport, there is a secretion released by your endocrine glands, and they are released via your bloodstream. Then they bind to your receptors on your target cells, and they have your response thereafter. So there will be cellular changes after binding of the hormone to the receptor target cells. So now, in your endocrine system, we have your negative feedback loop. So, in negative feedback mechanism, it is a regulatory process wherein a change in a system output leads to response that counteracts the initial change, bringing the system back towards a stable state. So, we have here initial hormone is secreted, and it will bind to your target tissue, and the rising levels inhibit the further secretion. Thereby, it's crucial mechanism for maintaining your homeostasis or a stable internal environment in biological systems and other systems, and in this instance, in endocrine system. So we have humoral stimuli, hormonal stimuli, and neural stimuli in your endocrine system. So humoral stimuli means changes in your blood chemicals. Hormonal stimuli means response to other hormones. And we have your nervous system activation with neural stimuli. So first, let's discuss your hypothalamus pituitary complex. So your hypothalamus produces your releasing hormones, and those releasing hormones will bind to the target cells in your pituitary. You have your anterior and posterior lobes. So your pituitary then will release the hormones, and those hormones will then be secreted, and it will be in the bloodstream and targeting your target tissues. So the target glands can be your thyroid, adrenals, and your pancreas. So your posterior pituitary gland, they only have two hormones secreted. You have your ADH or your antidiuretic hormone and your oxytocin. So your ADH regulates your water reabsorption and responds to blood osmolarity, while your oxytocin stimulates your uterine contractions and promotes milk rejection. This oxytocin is readily available for your pregnant women in labor. And on the other hand, we have your anterior pituitary hormones. So we have your mnemonic FAT LPG. So FAT LPG means FHH, ACTH, TSH, and you have your luteinizing hormones and your growth hormones. And that included here is your prolactin. So your anterior pituitary hormone secretes your growth hormone, which stimulates growth and cell reproduction. TSH, which regulates your thyroid function. Your ACTH regulates your and stimulates your adrenal cortex. And your FSH and LH controls your reproductive function. So your adrenal gland anatomy, we have your adrenal cortex means outer layer, and you have your adrenal medulla, which is inner. So cortex produces your steroid hormones, your medulla produces your catecholamines, your norepinephrine, and your epinephrine. So we have your general adaptation syndrome in your adrenal gland. So we have your fight or flight response. So it is mediated by your adrenal medulla, epinephrine, and your norepinephrine. Then we have your resistance stage, wherein the body adapts to stressors. So we maximizes the nutrient absorption, and we have your exhaustion stage. So long-term stress effects. So this is mediated by your cortisol produced by your adrenal cortex. So your adrenal cortex produces your mineralocorticoids. So the first example here of your mineralocorticoids is your aldosterone. So your aldosterone, it is triggered by your low blood pressure or volume. So what it does is it increases your sodium retention. So where sodium goes, water follows. And thus, it will increase your blood volume. And we have your renin, angiotensin, aldosterone system. So we have discussed this in the renal pharmacology. And one thing that I want to point out is that your aldosterone, it increases your sodium and your water retention, thereby increasing your blood volume and your blood pressure. And in your adrenal cortex, it produces your glucocorticoids or your cortisol. So your cortisol, it's a primary stress hormone, and it increases your blood glucose, and it has an anti-inflammatory effects in our body. And in your adrenal medulla, we have your primary hormone, your epinephrine, and your norepinephrine. So both of these can increase your blood pressure via your vasoconstriction, and it is used primarily in your fight or flight response. So we have your adrenal disorders. So we have your Cushing's, Addison's, and your Addisonian crisis. So your Cushing disease, it means that there is hypersecretion of cortisol. So one of the prominent features of your Cushing is that your patient has moon face and buffalo hump. While your Addison's, on the other hand, there is hyposecretion of your corticosteroid, meaning to say there is decrease in your cortisol levels in the blood. So meaning there will be low blood glucose and your sodium. And if your Addisonian crisis is not treated, it can lead to your Addisonian crisis. So it is a life-threatening condition wherein there is a severe hypotension for your patient. And if we are going to give patients steroids, we always assess the patient for any risk factors and pre-existing conditions. We check the height, the weight, and the blood pressure of our patient, and we check if there are CBC, glucose, or lipid profile results of our patient. And and we check if there are infections for our patients taking your steroid, because if the patient is taking steroid and they have infection, then it can exacerbate your infection for our patient. So we always teach our patients, if they are taking steroids, to never stop abruptly. So the primary physician will order for gradual tapering of your steroids. Then we always prevent your one of the side effects of steroid, which is your osteoporosis. So by giving patients with calcium supplements, and we can help them maintain their bone density by having your light to moderate weight bearing exercises. And we check also if the patient can be given with the lowest dose of steroid, then we use that. Then we regular the baseline measurements, such as your height, the weight, and the blood pressure. Then we check for weakness, fatigue, or malaise. And we check also the lab testing. So usually we get your early morning cortisol for your patients. So the mechanism of your corticosteroid is really to alter your carbohydrate, fat, protein, and your metabolism. So that is why one of the um, health education for our patients is really to take in your steroid capsules or tablets in the correct dosing and timing. And we always check there are infections because one of the mechanism of your steroid is really to suppress your inflammatory response. And if we give this to patients with infections, then um, we are exacerbating your infections because as we said, no, your steroids suppress your inflammatory response. So what are the corticosteroid indications? So it is usually used for your endocrine disorders, rheumatic disorders, allergic states, and your respiratory disease such as in asthma or in hyperactive airways. So we use your steroid. It may come into your inhaled steroids. We have your intravenous steroid, or it could be in tablet or capsule forms. And these are the side effects of your corticosteroids. So we have your adrenal suppression and diabetes in your endocrine system. Your cardiovascular, it can cause your hypertension and your dyslipidemia. So that is why we always check the blood pressure and the lipid profile of our patient. Then it can cause thin skin and poor wound healing in your skin. Psychiatric, it can cause mood swings and insomnia. And again, in immune system, it can suppress your immune system, thereby risking more infection. And skeletal, it can cause your osteoporosis and your fracture. So just to reiterate, in your corticosteroid, we never stop abruptly. We report infections, and we always consult your provider before receiving your vaccines. And we instruct our clients to take in more high protein, calcium, and potassium while taking your steroids. So let's go to the another endocrine gland, your pancreas. So your pancreas, it has an exocrine and an endocrine function. So your exocrine is your digestive system, which was discussed in your GI pharmacology. While your endocrine, we have your insulin and your glucagon. So what is then the function of your glucagon? So your glucagon, it triggers release from your alpha cells if there's a low blood glucose. So it will convert your glycogen to glucose via your glycogenolysis. And it can create your glucose from amino acids via your gluconeogenesis. And it can break down fats for energy, which is your via your lipolysis. So your glucagon, it will increases your blood glucose levels. And for your insulin, we have your beta cells. So your insulin enters your bloodstream and it will facilitate your cellular uptake of your glucose into the cells. And the excess glucose will be stored via your glycogen storage. And the food intake will trigger your insulin release. So in contrast to your glucagon, your insulin decreases your blood glucose levels. And with that, we will discuss your diabetes mellitus. So we have your type 1 and your type 2. So in your type 1, which is commonly seen in your pediatric populations, it is an autoimmune because there's no insulin production. So in your type 1, they typically require your insulin therapy for lifetime. In contrast, your type 2 diabetes, which is usually seen in your geriatric or in your older patients. So there is insulin resistance. It's because of your lifestyle related obesity. So in patients suffering from your DM type 1, they require a lifetime insulin treatment. So one of the guidelines in your insulin treatment, we use your rapid acting analogs. With this, we can reduce your hypoglycemia risk. Then we have to check the carbohydrates being taken by our patient. And some patients would require continuous infusion for those with hyperglycemia or with diabetic ketoacidosis, or those with uncontrolled sugar or glucose um, levels in the body. So these are your insulin types. We have your rapid acting, short acting, intermediate, and your long acting. So in your pharmacology book, we have a tabulation there of the different types of your insulin, their onset, the duration, and example of insulin. So if you are giving insulin, one of the side effects is really your hypoglycemia. And it's imperative for nurses to really know what are the symptoms of your hypoglycemia. So if you have mild to moderate, we can have your shaky, sweaty, and confused and irritable patient. And if you have severe hypoglycemia, we have a patient who is unconscious or having seizures. And one of the treatment of your hypoglycemia is to give an injectable glucagon because since insulin decreases your blood glucose level, your glucagon will then increase your glucose level. And we have to check the blood glucose via your RBS, your rapid blood sugar. So below 70, it's mean hypoglycemia. If there's no glucagon, then we can give your oral treatment. We can give your 15 gram of your carbohydrate if your patient is conscious enough to drink or eat. So insulin safety measures, we never share the um, insulin pen between patients. Some of the hospitals, they have your barcode scanning, and we coordinate the timing of your insulin. And we always discuss the self-management instructions. So in their homes, they should know how to inject your insulin. So this is particularly important for those geriatric patients. So we always assess your medical, psychological, and functional domains. No, so if ever your patient is having difficulty of remembering the timing of your insulin, we can give pamphlets or instruction guides, or we can involve the family for your um, elderly patients. In your pediatric, for those suffering from your DM type 1, we always involve here your parents and your family. So we always check also the nutrition therapy. No, so carbohydrates is really essential for these patients. And we check the growth of our patient, like your height and the weight, for these pedia patients suffering from your DM type 1. So as a review, we have your rapid acting insulin, so your novolog insulin. So we have your another is your Humalog, and we have your inhaled insulin. For your short acting insulin, we have your Humulin R and Novolin R. And for your intermediate acting insulin, we have your Humulin N or Novolin N. And for your long-acting insulin, we have your insulin glargine, and the brand name is Lantus, and we can have your insulin detemir. And your glucagon, It should be readily available in our emergency kit for those taking in your insulin, because one of the side effects of insulin is decrease in your blood glucose. So we give glucagon to increase the glucose in patients suffering from hypoglycemia. And one of the oral anti-hyperglycemia used in your DM type 2 is your glipizide. So the action of your glipizide is it stimulates insulin secretion from your beta cells. So since it stimulates insulin secretion, so your insulin then will be secreted and will cause your severe hypoglycemia. That's one of the side effects. So give your glipizide 30 minutes before meals. And the most used oral antihyperglycemia is your metformin. So your metformin mechanism, it decreases your hepatic glucose production, thereby improving your insulin sensitivity in your DM type 2. So it usually does not cause your hypoglycemia compared to your glipizide. And another oral antihyperglycemic is your sitagliptin. So your sitagliptin is a DPP4 inhibitor or your dipeptidyl peptidase 4 inhibitor. So it increases your insulin release, thereby decreasing your glucagon level. So it is used primarily in your DM type 2. And now your thyroid gland. So in your thyroid gland, it is located anterior to the trachea but inferior to your larynx. So it is a butter-shaped organ. So how is our thyroid hormone regulated? So our thyroid hormone, we have your T3 and T4. But if we trace back the production of your thyroid hormone, it starts with your hypothalamus. So in your hypothalamus, it releases your tyrotropin releasing hormone or your TRH. Your TRH then will bind to your pituitary target cells. So in your pituitary, it will release your thyroid stimulating hormone. So your thyroid stimulating hormone will be released into the bloodstream and it will bind to your target cells in your thyroid. There, your thyroid will produce your thyroid hormones, your T3 and your T4. And if we have a high T3 and T4, then we will have your negative feedback mechanism. So an increase of your T3 and T4 will decrease your TRH and thereby decreases your TSH. So that is your negative feedback mechanism in your thyroid hormone. So an increase of your thyroid hormone will decrease your thyrotropin and your thyroid stimulating hormone. And these are the functions of your thyroid hormone. So it increases your energy production and raises your body temp. And it will support your growth and development. And it is critical for your nervous system or your neurological function. And another hormone, aside from your T3 and T4, is your calcitonin in your thyroid gland. So your calcitonin, it is released if there's high blood calcium. It reduces your bone breakdown, so there will be osteoclast inhibition. Then there will be less calcium uptake by decreasing your intestinal absorption, and it decreases your urinary excretion, so there will be more calcium loss. So the function really of your calcitonin is really to lower your blood calcium levels. That is in contrast to the another hormone, which is your parathormone or your PTH released by your parathyroid gland. No, so your PTH increases your blood calcium levels, while your calcitonin lowers your blood calcium levels. So let's go now to your thyroid disorders iodine deficiency. So we often see patients having your goiter. So goiter, it means there is enlarged thyroid gland, and this is due to your TSH hyperstimulation. So We also have your hypothyroidism. So when we say about hypo, it means a decrease of your thyroid function. So there will be weight gain, we call intolerance. Some patients will have your fatigue and constipation, and they have reduced libido and menstrual irregularities. And in contrast to your hyper, they have high metabolic rate. So they have weight loss and heat intolerance. They have increased heart rate or palpitations, tremors, and they have bulging eyes, such as in your Graves' disease. So in Graves' disease, there is hyperthyroidism. And let's go to your parathyroid glands. So your parathyroid glands are embedded in your thyroid gland. So they are four tiny glands in within your thyroid. So the function of your parathyroid hormone, it stimulates your osteoclast, leading to your bone resorption. Then it increases your calcium retention, and it enhances your intestinal absorption. So your parathyroid hormone, it will be triggered by your low calcium in your body. So your parathyroid hormone, it increases your blood calcium levels in contrast to your calcitonin of your thyroid gland, which decreases your blood calcium levels. So let's go to your parathyroid disorders. We have your hyperpara and your hypopara. So in your hyperpara, we have an excess in your parathormone, leading to your elevated blood calcium, thereby there will be bone density loss. In contrast to your hypopara, wherein there is decreased or insufficient parathormone, leading to low blood calcium. So some of your patients have your muscle spasm or convulsions. And now let's go to your thyroid replacement therapy. So in patients having your hypothyroidism, we give your patients your levothyroxine. So your levothyroxine, it is given in empty stomach, um, usually given 30 to 60 minutes before breakfast with full glass of water. And for your anti-thyroid medication or for your patients suffering from your hyperthyroidism, give your patients with PTU or your propylthiouracil. So the mechanism of actions of your PTU, it inhibits your thyroid hormone synthesis, and it is given in 3 equal doses and 8-hour interval. So one of our assessment here is to regularly check your TSH and your T4 level, and the adverse effects is your liver injury, granulocytosis, and your vasculitis. Now, for your osteoporosis medications, we have your calcitonin. So we can give it via your nasal spray. So your calcitonin will decrease your calcium levels in your blood, and it will be deposited in your bone, so thereby increasing your bone density. So that is the mechanism of action of your calcitonin. Then we also have your alendronate. So your alendronate, is a biphosphonate medication used to treat your osteoporosis. So it is taken by mouth, and it is often recommended together with vitamin D and calcium supplement, and also with your lifestyle changes. And your calcium plus vitamin D, we have here in the market, no, it is used to boost your bone health, and your vitamin D aids your calcium absorption, and it prevents your osteoporosis. So it is taken with food, and we monitor your patients for any symptoms of your hypercalcemia, and we watch for any kidney stones. So that's it. Thank you for listening.